May 1st through Thursday, May 4th. Hi, everyone. My name is Lauren Downing, and I'm an event manager here at IHI. And we want to welcome you all to the Hospital Flow Professional Development Program informational call. As you know, our program will take place here in Cambridge, Massachusetts from Monday, May 1st through Thursday, May 4th. And before I turn it over to Pat Rutherford, who's one of our vice presidents here at IHI and one of our key faculty for the program, we want to encourage you to type any questions or comments that you may have throughout our hour together using the chat box in the bottom right-hand corner of your screen. We'll be monitoring the chat throughout our time together and encourage you to keep this call interactive. And with that, Pat, I will turn it over to you.
Thank you, Lauren, and welcome to all of you that have joined this information call. I will go through this slide deck that I believe you will be able to download. Lauren will give directions, if you don't already have that, about how to download the slides. And I will give a very comprehensive but brief overview of content that will be covered in this 4-day program in May. We have done innovation work at IHI over the last year and a half to come up with what we think is a comprehensive sense-making approach to all the various components that are required to really solve this very difficult, challenging problem in hospitals, not only in the U.S., but worldwide. We're finding out it's a huge problem in most countries. And we think that from the feedback that we've gotten from the first two of these programs, that participants feel that it was very helpful to have this comprehensive approach that uses improvement science as well as lean thinking and hospital engineering and systems engineering approaches. So hopefully you will get a good idea of what this program will offer in the spring. I can't, Lauren, for some reason I can't advance the slides.
I'll take the ball back from you and then pass it back.
Thank you. Maureen Bisignano posted a blog post in August of this year about what she called flow failures and how they are disrespectful to patients. Basically, really thinking about it from the patient's perspective, that it's really not valuing their time. And in many cases, it can lead to poor quality of care if people do not receive the care they need in a timely manner and also in the best setting. So we will talk about both of those and how patient flow is not only an efficiency thing that we're trying to do with hospital throughput, and efficiency is certainly part of what we're trying to accomplish, but also we want patients in the right place at the right time for the right care, and that is critical for patient safety objectives and strategies as well as patient experience. Next one, Lauren. This is a website by Jess Jacobs. She was a director at Aetna's Innovation Lab. She had two very, very rare disorders that required her using the healthcare system quite a bit in her limited life.
Welcome to WebEx.
She had ongoing struggles with kidney infections, shingles, pneumonia, many pulmonary emboli, and had frequent transfusions. And if you go on her website, she really makes a few posts that I think are very poignant about the amount of time she spent not only in outpatient care and visits and emergency room visits, but also time within the hospital. And her, Lauren, can you try to give me the ball back again, see if I can do this, because it's a little challenging about moving the slides timely. Could you try that one more time, Lauren?
You have the ball now.
Okay, let me see if I can do it. Okay,
there you go.
It's working now. Thank you. Basically, what was really poignant and what really struck me when I read her post is the lines that are highlighted here in red. I'm missing out on life. She died when she was 29 years old, and within the last I believe, year of her life, she spent an inordinate amount of time with what we would call waste. And it's not just waste and efficiencies within the healthcare system. This was time away from her friends and her loved ones and her family in a very limited life. So it's a very dramatic depiction of the burden and I think tragedy for patients that poor patient progression or hospital flow can lead to. Don Berwitz also had some poignant remarks in the book Leadership for Smooth Patient Flow, which I contributed to, about really using the complex theories and science behind changes in other industries, and how, just like safety, we can learn from aviation industries, we can learn from other industries about how to improve flow. There are tried and true strategies that clearly will be helpful to hospitals and healthcare systems. So we don't need to invent new theories. The theories are there. The difficult task is how do we apply them to our complex systems within healthcare. So our problem statement really for hospital flow, what we're trying to contribute to, IHI does not feel like we're the only ones that can contribute to this problem, but we think that the integration of improvement science and our connections with a lot of great expert faculty and experts in the field, that we think that we're coming up with an approach that we think might be helpful in combination with other things that hospitals are already doing. And so our mantra is right care, right place at the right time. And in addition, in the second paragraph there, in addition to being an issue for patients and family members, it also has a very, very big impact on clinicians and staff, and I think leads to a lot of the burnout and stress that staff are feeling. EDs, many folks are starting in the ED. The ED is a place within the healthcare system that's very challenged these days, with increased patients coming to emergency rooms with very complex problems and mental health issues. And so many are working on the ED, but quickly those that are doing that will find that fixing and improving the hospital flow within the hospital through all the inpatient units is critical to solving some of the problems with the ED for patients that need to be admitted. And then boarding of patients, I think, is something that hasn't been talked about a great deal in regard to patient flow, but we are increasingly concerned about patients that are on, quote unquote, an off-service unit or being boarded on a unit. So that, now hospital care is so specialized that if a patient has an orthopedic, a transplant or has a very specific knee replacement, not a transplant, I guess it's not a transplant, but a replacement of their knee, that having them on a medical unit, perhaps an oncology unit or just a general medical unit, that the expertise of that nursing staff and the proximity to the doctors and the whole care team, we think, will likely lead to substandard care. And I think that it's something that I think we need to look at increasingly in regard to patient flow. So unfortunately, understanding the problem, I think most of you are very, very aware of all the challenges and the problems, but actually improving it is really another big challenge. So we undertook going to look for best practices internationally and throughout the U.S. and any place that we could find innovative approaches to components of solving hospital flow. And then we have engaged with expert faculty to put together a very comprehensive approach through our R&D processes. So I'd like to ask you to take a second now to use the chat function and type in what are your key performance goals in 1 or 2 lines, and just think for a second about what success would look like for you. And there's a little and their icon just below the participant list there. If you're having challenges with the chat, please put your hand up there and just click on that icon. Okay, I'm going to move along. It seems like many of the posts that you're putting there are absolutely in sync with what we are approaching. Not sure I understand the wait time in PCP. If I understand PCP to be the primary care provider, but maybe there's another definition of that abbreviation. So I'll move on to what we think our recommendations are for performance goals that would help focus people's efforts in system-wide hospital flow. So first is decrease the overutilization of hospital services. So in other words, are there patients coming to the emergency room and are in beds in the hospital that could, should, and would perhaps be cared for at a higher quality in a different setting? So for example, many patients coming to the emergency room for routine primary care kinds of symptoms and problems. Could that and would that be better handled in a continuity relationship with a primary care provider outside of the ED? That's one example of that. Another is overutilization of individuals that either haven't declared their wishes for end-of-life care, or the hospital does not have a good plan for how to best meet their wishes for the end of life. And we hear many stories from families that some of their loved ones die in the intensive care unit, but if things had been different, that wouldn't be their first choice, or that wouldn't be their preferred way to have the last days of their life. So that's just a couple examples there. Second is optimizing patient placement to ensure the right care in the right place at the right time. We've talked a little bit about off-service patients, external and internal diversions, maintaining adequate staffing levels to maintain high quality and safety with variable census. That's a huge challenge. Increase clinician and staff satisfaction with hospital operations. I don't often see that on dashboards for flow initiatives, and I think it's very important and should be added. And then demonstrating a return on investment is also becoming increasingly important for the hospital and the healthcare system. And we'll talk a little bit more about average occupancy and utilization on the next slide. I was able to pull this data from Massachusetts. We don't have recent data from the recent years. But this is a comparison from 2012 and 2013. And there's not a great deal of difference between the years for each of these segments. And what is a common trend both nationally and within most states is that the academic medical centers and teaching hospitals we usually have a higher occupancy rate than the community hospitals and some specialty hospitals. Now, when you think about this, and I've read some commentaries about folks in other industries and people looking at the healthcare system and policymakers looking at this data, and if someone would say, even the academic medical centers that have a higher occupancy rate, around 85%, the question is, well, what's the big deal then? There's 15% unused capacity. Why are hospitals struggling with hospital flow and utilization? And the next slide shows why. Because there's a big difference between average occupancy rates that I think really is not how we manage day to day, both at the hospital and the unit levels, but the day-to-day realities of managing patient flow are very similar to this pattern. Whether you're looking at the hospital or whether you're looking at a particular intensive care unit or specialty units or general medical and surgical units. There's a tremendous amount of variation amongst the census from day to day, month to month in some cases, and then there are some seasonal variations. And I think that this is one of the things that one of the fathers of quality improvement, W. Edwards Deming, says that the most important thing that we can do is to manage variation. So this means taking a look at what are the variation patterns of high time-intensive things such as admissions and discharge within the day. What about day-to-day variation in census? In most cases, we've heard that Tuesdays, Wednesdays, and Thursdays are the most difficult days, and when there's most patients being boarded in the ED, and oftentimes OR cases, patients are recovered in the recovery room if there's not an inpatient unit. So those are patterns that the first thing you need to do is really understand what are our patterns. What are your day-to-day patterns of activity that need to be considered and managed? What about day-to-day variation? What about month-to-month variation? And then how do you proactively plan? What we've seen in many cases, if not all cases, is that there are predictable patterns once you take a look at this. And then once you understand that, there are ways to either manage that or reduce some of that variation. This next depiction is our team's approach at taking a look at hospital flow as a complete system. And so this is not accurately depicting any one hospital. It's Kathy Luther, who's on the call, another vice president at IHI's. Our best depiction about what we think the volume of flow for all these different pathways in the hospital are. So the red arrows are inputs to the hospital, and the blue arrows are pathways between units within the hospital, and then the green are outputs, where patients go after they have an encounter within the hospital. The thickness of the lines depicts what we think is the volume, and it's probably not accurate, but it's a pretty good from the first two cohorts of participants in the program say that this is a pretty good depiction if you're looking at it generally. A few places have taken this depiction and have customized it to their own hospital because obviously there's more than one acute care, med-surg unit, and some had mental health units that they added. So this could be customized to your particular setting. And what we think the usefulness for this is to show for the individuals that are working on flow initiatives within the hospital that this is a system issue. If people are working on only isolated projects in different parts of this system, they're less likely to have the outcomes they're looking for, as opposed to looking at flow as an entire system and having a portfolio of projects in high leveraged areas where you're challenged would be a better approach. So this is not only useful for people that are working on hospital flow, that this is part of your responsibilities, but also in talking with CEOs and senior executives and even perhaps the board about the complexity of this problem and how you are approaching it with a portfolio of projects. So, as I mentioned, strategies from other industry are very, very applicable to this problem within healthcare. So we have adopted this as our main framework for looking at solutions to hospital flow. And the three main strategies are shape the demand, match the capacity and demand, and redesign the system. Most folks are working on matching capacity and demand, and that's what they spend a tremendous amount of time doing every single day and weekly perhaps, and maybe even seasonally. And some are redesigning the system, particularly the throughput in the operating room and throughput and efficiency measures in the ED, and some on med-surg units and other parts of the hospital. But very few are looking at shaping the demand. And what we mean by that is really, are there better ways to meet the demand than just assuming that the demand we have is just going to be, that's the way it's always going to be. There are ways to shape that demand, both in flows of activities into the hospital and types of patient needs, meeting them in different ways. And also, what are the scheduling ways that we schedule ORs and diagnostic procedures? Are there ways that we are contributing to variation by how we electively schedule some of those activities that we could get a better control of variation if we looked at scheduling in a bit different ways? This is a little hard to read here, but this is our overall strategies for achieving system-wide flow. The approach is will, ideas, and execution, that we need to have will. The senior executives have to have this as a priority. Mutuality between physicians and hospital executives is key. Aligned incentives, and those that are working toward value-based models of care, this will be more attractive to them than those that are not on that pathway yet. The ideas that I mentioned, the green, the blue, and the purple there, shape demand, match capacity and demand, and redesign the system. Have another slide that has much more detail on those. And then execution is very, very important. You have an accountable executive leadership team that's providing oversight to these system level performances? Is there capacity at all levels to use metrics and data analytics to really understand your problems and help you with shaping solutions? And is there cooperation across units and with care settings outside the hospital, such as skilled nursing facilities, primary care, and mental health services? And the next one is even harder to read, and don't worry about that. You can download it and see more detail, but I'm going to have other slides that depict the detail. And the reason that we put this here is that we wanted to show you that really it's a very comprehensive strategy, and you can see the very specific ideas that we've harvested and have expert faculty to teach are a significant number of specific change ideas there on the far right. Draft flow metrics, these are things that you can take a look at after the call, of things that we think could be helpful to you, and you might want to compare this to what you're already doing and see if any of them could benefit what you're doing already. And here's a little more detail on the shaping or reducing demand. So what we mean by that, I've already touched upon the relocating care in ICUs in alignment with end-of-life wishes, decreasing bed days by avoiding preventable, avoidable readmissions, and probably every one of you are working on readmissions in some capacity. So it's not only an isolated project over here on the right, it also has a big impact on flow. If you were successful in reducing a significant number of readmissions that could be cared for better in the community, then you will have available beds to give you a little bit more flexibility on those really busy days. And then S3, the secondary driver, relocating low acuity care in the ED to community-based settings, primary care, specialty clinics, routine mental health services are the kinds of things that we're finding are useful there. Prevent ED visits and acute care by better case management and complex patients and chronic disease management in primary care and specialty care. And then the surgical scheduling variation is one of the big things that creates a lot of artificial variation by the way surgical cases are scheduled, particularly the very complex cases that require ICU stays, significant ICU stays, and significant length of stay on medical and surgical units. And then the last two are really linking with safety and reliability and evidence-based care that probably is part of your strategic priorities as well. And it's reducing harm and hospital-acquired conditions. Every time someone has a pressure ulcer or sepsis or any other acquired condition in the hospital, that generally reduces the length of stay by a significant amount and then utilizes beds that otherwise could be freed up for other uses. And then delivering appropriate care using evidence-based care and protocols to really standardize care and have that appropriate care being delivered very reliably. So relocating care, I've already mentioned these three approaches. IHI has two projects focused on end-of-life care and versus the Conversation Project that activates patients and family members in the community to talk about what their wishes and have loved ones know what their wishes are. And then the Conversation Ready is really activating the healthcare system to be able to honor those wishes. Gunderson Lutheran has particularly done a tremendous job with their Respecting Choices program, and you can see here how, first and foremost, this is a patient-centeredness initiative to really honor patients' wishes, but it also has utilization impact, that really reducing unnecessary care in the hospital by honoring their wishes. This is results from some very significant work at UCSF on reducing primary and secondary heart failure. And you can see here the decline over these years of patients that are not coming back in for repeated admissions for heart failure. And if you add up the bed days that are saved by all those admissions, it's very, very significant. Many creative, innovative approaches now are emerging in addition to what I've already mentioned, using paramedics and emergency medical services to respond to needs through 911 calls, to assess patients in the home, sometimes using telemedicine and consultation with physicians, and treating them for whatever the condition is in place in the home, and preventing frequent ED visits. Community health workers, particularly in Oregon, they've got a great program in their Medicaid program, connecting individuals with community-based services, particularly for mental health, has significantly reduced their utilization. Atrius is a very successful health AC Boston area. They're really the central focus for their ACO, and they have demonstrated fewer use of with Medicaid, Medicare Advantage, PPO, reduction in admissions and significant reduction in emergency room visits through robust primary care, connection with home health care, and proactive chronic disease management. And the work largely has been done by Gene Litvak and his organization. He's been a leader in hospital flow for many, many years through using hospital and systems engineering. And one of the very dramatic improvements that hospitals are starting to see is separating the flows for elective and non-elective surgical cases within the OR. So in other words, not using the same room for both kind of cases, because it disrupts the elective schedule, bumps cases into the evening, and requires a lot of overtime. By simply designated, by understanding your flow patterns and your volume, by understanding about how many beds or how many suites, actually, OR suites, need to be designated for emergent cases, then those patients just go to those rooms, and then elective surgery stays more on schedule throughout the day. And hospitals that have done that have seen results as what was published from Mayo Clinic in Florida on this slide, which is very significant. And this is a little bit of a complicated slide, but the work at Cincinnati Children's, they've done a lot of work using their analytics and understanding patients that need ICU, extended ICU stays. If you look, they're the long cases over there on the far right of this chart, 11% of the cases, but 30% of the days in this intensive care unit are from these cases. So managing and spreading those over days, not having them clustered all happening on Monday, can significantly reduce, overutilization of ICU beds in clusters and smooth out that schedule. And they've done some very, very dramatic work. And even though they're a pediatric institution, every single thing that they have done regarding hospital flow is applicable to adult settings as well. C. diff, here's a paper that talks about C. diff infections, which are still happening at a very high rate in hospitals, increase patients' length of stay. And if the safety issue can be addressed, then there are bed days that will be freed up by doing so. Next is matching capacity and demand, which most of you are really doing on a daily basis. Many have daily bed huddles, but thinking, proactively about that and really putting a little more rigor into predictions and assessments, we think can augment what most folks are already doing. Can you predict the surge in admissions for medical patients in the winter months? What proactively can you do about that? Are there flex units? Can you bring in additional staffing during those months? Can you anticipate which units need more capacity? And one clue is which services consistently have a large number of off-service patients, and how best can that be managed and looked at within the whole system? And do you have regular surge activities midweek, as I've already discussed? This is a flow pattern that is pretty common in most emergency rooms. The RN demand is in the bars, and the total RN staffing. So they really have looked at what the demand is at times of day, and they've adjusted their scheduling patterns within the ED to match that demand. And that's really one of the big efficiency changes, and matching capacity and demand, things that really is helpful in emergency departments. The inpatient units are a little more challenging because of the variation that I talked about earlier, both at the hospital level and at the unit level. And clearly, there are challenges of doing this. So on the left-hand side, if you were to staff for 95% of the census and occupancy in this particular unit, you would have really good staffing all the time for the peak demand. But what happens when the demand is much lower? Then you have overutilization of nursing services, which is very costly. The challenge is on the right side, if you staff for the averages, then what happens is that we have adequate nurse-patient ratios when you meet the highest demand there at the peaks. And then there is a little more challenge with, less challenge than the left-hand side with overstaffing, but it is really challenging on a day-to-day basis to manage this. So we think that there's two strategies. One is variations such as this would help decrease the peaks and valleys in both of these pictures. And then secondly, coming up with flexible staffing approaches would be helpful to these scenarios. Here's some ideas from Jean Litvak about nurse staffing and operations. You can the staff according to the peaks, be creative, have dynamic and flexible patient-nurse ratios, legislate nurse-patient ratios as they have in California, and I think there's mixed reviews about results there. Preserve the status quo, do nothing, and then you sort of get the problems that you have today, or look at flow management. And I think a combination of these approaches is what's needed. Real-time capacity and demand management is one of the things that IHI has done over the years, and putting more rigor into the daily assessment of capacity and demand at the unit level. Predicting capacity, predicting demand, developing a plan to address mismatches if they're there, and then evaluating the plan. And doing this through iterative cycles has proven to be very successful in helping do better predictions and better planning for mismatches there. And if there are recurrent patterns of, if you're developing the same plan every day for the same problem, then perhaps that needs to be a project that needs to be addressed through some redesign work. And these are some results by using this approach at one of the hospitals at UPMC in Pittsburgh. And surge plans, I think most places now have some kind of status depictions throughout their hospital or hospital system, multiple hospitals perhaps. But what really is really important is first is having the segmentation of, what do we do? I mean, where are we? Are green, yellow, orange, red, or some other color? But what's even more important is developing plans for when you're yellow. What do you do differently in your day when you're yellow? What do you do differently when you are orange? And what do you do differently when you're red? And the testing of approaches for each of those strategies is really important, and a good learning system will help organizations to perfect that. Redesigning the system is last approach through the OR, the ED, ICUs, and med-surg units, coordination of discharge processes, and trying to smooth the demand within the day for when patients are discharged, particularly for the workload for nurses and doctors, social workers perhaps also, and case managers, and smoothing that out and having some of them happen earlier in the day. Service line optimization, reducing length of stay outliers, and optimizing patient progression throughout the hospital. This is some phenomenal work that's been done at Cambridge Health Alliance about in a safety net provider hospital, and they have had a tremendous increase in their volume in their emergency department. But through redesign of their processes within the ED, you can see how the median length of stay of patients has dramatically increased at the same time that they have dramatic increases in their patients that they're seeing in the emergency room. Folks at KP Sacramento also have had tremendous progress through their efforts in improving ED flow, and you can see the before and after, the hours on diversion, the percent of patients left without being seen, door-to-doc minutes, the time for that has dramatically been reduced, length of stay for those that are seen in the ED and sent home, and then length of stay for patients that are there longer and are generally admitted. This is some really interesting work that's been done, again, at Cincinnati Children's Hospital, where they have been working with the medical services there. And on admission to one of the med-surg units, what they are doing is they are writing criteria for discharge based on the patient's clinical condition. They have standards for this, for the common diagnoses that have been collaborative efforts between the whole care team, the nurses, the doctors, care managers, social workers, physical therapists, whoever is involved in the care of the patients that are commonly cared for there. And they now have, criteria for discharge for the common diagnoses, for those that they're evolving, others for the less common ones, but generally are conferring, having the doctors and nurses and other care team members think about that earlier on when they're admitted to the unit, as opposed to thinking about that later down day 2, 3, or 4 of the hospital admission. And what their goal is to discharge patients within 2 hours of when they're medically ready. So generally the nurse will, I think it's in Epic, they click a screen within Epic. When they have met the criteria for discharge, they click a screen in Epic, and then basically the whole team is mobilized to try to get the patient out within 2 hours of that time. And that's been hugely successful in having more timely discharges and having better processes through more proactive planning up front. The other thing is they've also engaged patients and family members by having the discharge criteria posted in the patient's room, so that the family members also are aware and are proactively being ready and arranging transportation and other things, so that they can be ready to go home when the patient is clinically ready. Really phenomenal, great work. And also phenomenal, great work at Memorial Hermann, working on all aspects of care within the intensive care unit, sepsis management, weaning protocols, BAP bundles, standardizing family meetings and proactive care and planning for care and in some cases end-of-life care, has resulted in better throughput within their ICU. And they initially thought they needed more ICU beds, but they were able to manage patients effectively and have decreased length of stay, which also freed up beds. And they didn't need, at this point, I think this was a couple of years ago, did not need to increase and build new ICU beds. Now, I think their volume is increased again, and I think they may have to relook at that and may have to add more beds now. But at this point, through efficiency changes and safety changes and reliable care, they were able to manage within the bed capacity they had. So the first step would be to do all of these things and then really understand what the length of stay is before costly renovations and adding, which is very, very expensive. And these are some of the outcomes from that work at Memorial Hermann. And last but not least, again, you'll have to download this to see the details. We strongly recommend that hospitals that are setting their sights on really having results at the system level to create a portfolio of projects across all of these microsystems, per se, at the hospital level, and these in the emergency department, critical care, med surg, and operating rooms, and all of these approaches, and pick things that you think that are highest leverage. So now we'll move to our program in May. It's a 4-day intensive shared learning and capacity building and capability building. We have about 20 leading healthcare expert faculty presenters, and we provide opportunities to collaborate with other participants in the program. Pre-work, we will send out some pre-work and ask for a little bit of data collection so we have a sense of where people are working and where the strengths and weaknesses of their approaches are. There'll be working sessions with team members, and then there'll be exchange of ideas with the participants and the faculty, and ad hoc coaching sessions. Who should attend? We strongly recommend that a team that's accountable for hospital flow be those that attend, and we have gotten feedback from teams that have done so and have felt that that's been very effective, not only in the learning together about the different approaches, but the planning time off-site, and also the informal team building when they go out for dinner has been very, very helpful to have teams that are responsible for this. An individual from a hospital could certainly come, but we think that bringing a team would you get the most out of the program. And what you will learn is basically all the things that I've described in this presentation and is summarized in this last slide. So I think we have about 15 minutes, and I don't know if people have been adding questions in the chat, but if you haven't and you have questions that I haven't covered, myself, Lauren, and Kathy would be happy to entertain those questions now. Kathy, if you want to sort of triage them and let me know, that would be
yeah. I think there've been a couple of questions in the chat that Lauren and I've been able to answer. A couple of questions about the slides, and will they be shared? Lauren just posted the URL into the website. I think this is a relatively small group. If any of you want to really ask a verbal question, you can raise your hand. I'm hoping that's correct, Lauren, and or you can chat a question or a comment into the chat. And I guess from IHI point of view, we'd be interested in your reaction. Do you think this will meet your needs as a facility? Are there anything missing that you might want to include or we might have missed, or anything that you want to add? We do have a question in the chat of the threshold for goals or measures, and are they based on region? What we know about the measures right now is we see very few facilities tracking any kind of a family of measures. So that's number one, is to develop that family and start tracking. The second thing is, I think for each organization, to set the goals and the measures based on your own situation. We realize there's certainly regional differences and facility differences, and to really look at what your current performance is, to make that visible to a team within your organization, and then to actually be able to decide on what you're going to improve or not. We have seen a couple facilities, and we'll share this, Memorial Hermann being one of them that Pat was referencing, made some changes, and they really didn't see the results until they really looked at the whole family of measures as to what kind of spill out there was going to be in other parts of the hospital. So a lot of times we make decisions that we think will help alleviate flow, adding beds, decreasing beds, moving things around. But the family of measures really helps you see the real impact on your system when you can look at them all together. The second question is, I'll start it, Pat, and then maybe you can add, will the focus be foundational or appropriate for experienced teams looking to make gains? I think it's both. I think experienced teams will learn a lot from folks that are doing this and have tackled tough problems. Hopefully they'll get some new ideas and maybe new nuances that they hadn't thought about. I also think it's very useful for foundational teams to begin from a point of reference and to do kind of a checklist to see what they have working and what might move them ahead further faster. Pat, do you have anything to add to that?
No, Kathy, I agree with what you said. I think that the feedback has been pretty consistent across teams that have been there, whether they're advanced or whether they're just beginning. They feel like, I think everybody has gained something and is able to take next steps. We've had some follow-up calls that have really been very encouraging, that people have been able to take some of what they've learned and put it into action fairly quickly. There is another question by Anthony. It said, do you have any outcome data from past participants? This is not an ongoing collaborative like some of IHI's programs that are results-oriented, that take place over a period of time where teams are engaged with us, for example, in hospital flow, and they would be implementing components of what's depicted in this model. And then over time, they would have outcome data and show how the interventions were being implemented and what the results were. So we don't have outcome data to share from other participants. Folks, we did ask folks last time to bring a storyboard about their current work in hospital flow and sort of what are they focusing on, what are their main areas of focus, what are they having some success with data if they have that, and then what are their biggest challenges. And I think the majority of folks from our program in November did that, but we don't share that publicly, so that is something that is just shared amongst the participants in that particular program. And we will do the same and ask for that for the program in May. Folks felt that was very useful for networking and learning about other organizations that were doing similar things to what they were doing.
Yeah, and just to add to that, what Pat said, actually a couple hours from now this afternoon, we will have the teams that were in the fall group back together, and several of them have agreed to share their work, what they've learned, and what sort of ahas they had and things that they've taken back and implemented within their own organizations, and the changes that they have actually made from the course that we did in the fall. Pat, we have another question about as hospital flow is optimized, how it's related to the quality of patient experience from the patient perspective. And no, it is not out of scope for this discussion. We certainly see many organizations linking patient experience data, whether that's HCAP scores or something else, with improvement in flow. And obviously frustrating to the patients and the staff are extreme waits and wasted time and when am I going home, and people seem disorganized. And I think the more tightening that goes on around this, I think it really is reflective in the patient experience from the patient perspective. And different organizations have various ways of measuring that, but it's certainly not out of scope, and it's very important.
Absolutely. I think if you look at both in the outpatient settings and within the hospital, I think waits and delays is one of the biggest dissatisfiers that contributes to their overall evaluation of their experience, whether it be in primary care, specialty care, or within the hospital, for sure. Absolute link. I think, it's really hard to know exactly, what the impact of changes in hospital flow have on overall patient experience, and the same with safety. But we think that those three really strategic priorities of every organization are very, very intertwined and interlinked and integral. Have to, pick that out, I think, is going to be hard, but certainly it's in the family of measures. If you look at our draft flow metrics, it's in the list of hospital macro metrics. Patient experience is listed there let me see, that's on slide 19.